Welcome back. I am Dr. Vanetta Williams, your NCRA 2020 Program Committee Chair, and I will be your afternoon moderator. As a reminder, be sure to use the Q&A tab on this screen to ask any questions of the speakers. Following each case study, I will be coordinating your questions live with our speakers to provide you with real-time answers. With that, let's move into our afternoon program.
In this program, our physician presenters will provide an in-depth review of case studies for 3 sites: breast, gynecologic, and head and neck. Each session will feature detailed case presentations by physicians who will demonstrate how to assign AJCC TNM stage. Our CTR presenters will address the same case studies and determine summary stage, the site-specific data items, grade, EOD, and the application of the solid tumor rules. We will conclude each site with a Q&A from the audience. Our first anatomical site is breast. Our physician presenter is Jennifer Garreau, MD. Dr. Garreau is a board-certified general surgeon and surgical oncologist with Legacy Medical Group Surgical Oncology in Portland, Oregon, specializing in breast cancer and melanoma. Dr. Garreau earned her MD from the University of California, Los Angeles School of Medicine and completed her internship and residency in general surgery at Oregon Health and Science University. Peggy Adamo is the CTR presenter for the breast site. Ms. Adamo is a public health analyst with the Data Quality, Analysis, and Interpretation branch of the Surveillance Research Program within the Division of Cancer Control and Population Sciences at the National Cancer Institute. Let's begin. Please welcome Dr. Jennifer Garreau and Ms. Peggy Adamo.
Hello, and thank you for having me here today. My name is Jennifer Garreau, and I am one of the surgical oncologists at Legacy Cancer Institute in Portland, Oregon. And I want to thank the NCRA for the opportunity to present these cases today. I had the opportunity to present about 2 years ago, and I have to say it was a lovely experience. And my only disappointment this time is that I cannot see all of you because last time the engagement from the audience was just tremendous. Anyways, I'm very happy to be here today, and let's go ahead and get started. So, case number 1 is a 68-year-old female who felt a tugging or pulling of her right breast while she was laying in bed. She then checked the right side of her breast and she noticed that it felt really hard and that the nipple was inverted. She then compared this to the left side, which felt completely normal. This prompted this patient to call her doctor, who then ordered the following imaging. So these pictures here are called diagnostic mammograms, and a diagnostic mammogram means that you're looking at a specific area of concern, as opposed to a screening mammogram, which means just what it sounds like, you're going in just for screening. Now on this, it's a little bit hard to appreciate, but I'm going to show you here with the pointer. See, thankfully the radiologist gave me a love note. That's what I call these arrows. But you can kind of see that there's a little bit of an asymmetric density right here where the pointer's circling. You can also see, it's hard I'm old now and I can't see these things. There's a little triangle sticker, which, sorry, now I'm so far away I can't see it. Anyways, but when you have a palpable area of concern, the radiology tech will place a little triangle sticker that denotes the area of concern so the radiologist can focus on that area more closely. But on these images, there was this asymmetric density here and here, and the radiologist said it was about 1.6 centimeters in maximal dimension. So that's what started the workup. And then the patient went on to have an ultrasound to further evaluate that area. And you can see here that there was this irregular hypoechoic solid mass. This is the same thing on these 2 views, just shown in a different angle. And you can see that in this dimension, it was about almost 1.9 centimeters. And then in this dimension, it was 9 millimeters. And then in this dimension, it was just a little over a centimeter. So not that big, but a little bit irregular. Now, usually when I talk to patients, I will at this point then do a physical exam. But this particular family, they started asking me a bunch of questions about treatment. So I started to talk to them about treating a 1.8 centimeter cancer. And then I went and did the exam. Oh, and I forgot to talk about the biopsy, sorry. So she then went on to also have an ultrasound guided core needle biopsy. And this picture here, you can see the needle here going right into the mass. And that's one of the ways that we confirm the proper area is being biopsied. So the final pathology on this showed an invasive ductal carcinoma, grade 3, which means high grade. And this was estrogen receptor and progesterone receptor negative. It was HER2 equivocal on the H&E staining. And then it was negative for amplification by FISH. Now, FISH stands for fluorescent in situ hybridization. It's just a different molecular technique for the pathologist to figure out whether or not these cancer cells are overexpressing this HER2 protein. Also, you'll notice that the proliferative rate or the growth rate was exceedingly high at 91%. That means that those cancer cells are really growing really fast, and that is a concerning feature. So, after I talked to them a bit about how to manage a 1.8 centimeter cancer, I then said, I really should do the physical exam. So when I examined the patient, the entire lower pole of her right breast was just a hard rock, and it looked very concerning for involvement with cancer. And I would say it measured at least 4 centimeters on physical exam, if not larger. I did not feel any enlarged lymph nodes on physical exam, and they did not see any enlarged lymph nodes on imaging either. So it looked, at least it was large, but it appeared to be contained to the breast. Based on the size of the tumor and the fact that it was hormone receptor negative with that very high proliferative rate, we then ordered a staging workup to make sure she didn't have any disease anywhere else in her body. So she got a CT of the chest, abdomen, and pelvis, as well as a bone scan, both of which were negative for distant metastatic disease, which is excellent. As part of her workup, she also got something called a breast MRI. And this here is just one of the representative pictures that we obtained from the breast MRI. And you can see that there's marked asymmetry between the right breast here and the left breast. This left breast is completely normal. That's what a normal breast looks like. This right breast here, all those colors that you see, the blue, yellow, and red, that's what's called increased enhancement. The enhancement is essentially the uptake of the dye that's injected during the study, and that looks at blood flow patterns. And that's how we can tell if a mass is malignant or concerning for cancer or benign. And in this situation, this uptake pattern of the dye looks extremely concerning for a cancer. And you can see it involves almost the entire breast, all the way from the nipple, heading all the way back. And then the radiologist measured it at 5.2 by 7.4 by 2.5 centimeters. So that's pretty large and significantly different from what we saw in the ultrasound and the mammogram, right? They also did not see any adenopathy on the MRI, which again is a good thing, but still she has this pretty large tumor. So let's talk about the staging. So again, initially when I met her, just based on my physical exam, I staged her as a clinical T2N0M0 because remember the T2 designation means a tumor size between 2 and 5 centimeters. So on physical exam, I did think it was less than 5 centimeters. However, then we got the MRI. And based on the MRI findings, we did find that the tumor was greater than 5 centimeters, but it did not involve the skin or the chest wall, and this is not an inflammatory cancer. So for that reason, she then was classified as a T3. The lymph nodes are still classified as an N0 because there was no evidence of any lymph node involvement. And then the staging workup showed that she had no distant metastatic disease, so she was classified as an M0. So remember, in 2018, the 8th edition of the AJCC staging came out, and that really significantly changed how we stage breast cancer. Previously, we used to only do the staging based on the size of the tumor, the status of the lymph nodes, and the presence or absence of metastatic disease. That's that TNM staging system, right? So that we now refer to as the anatomic stage. And so her anatomic stage was a stage 2B. But the 8th edition of the AJCC that came out in 2018, they now include the prognostic factors such as the hormone receptor status, the HER2 new status, and the grade. And based on that, you can see in this patient that it significantly changed her stage, and she actually was upstaged to a stage 3B. And that's because we now know that those prognostic factors are probably more important than the size of the tumor and the status of the lymph nodes. And that's why they were included in this new staging update. And that's why this patient was upgraded, because she had worrisome prognostic features such as the hormone receptor negative expression and the high grade, because remember she was a grade 3. So that's her staging. So let's talk a little bit about her treatment. So because she had this large triple negative breast cancer, it was recommended that she get something called neoadjuvant chemotherapy. Neoadjuvant just means some sort of systemic therapy before surgery. And in this situation, she got chemotherapy. And she got something called dose-dense AC. That stands for adriamycin and Cytoxan. Those are two of the most commonly used cytotoxic chemotherapy agents we use in breast cancer. She received 4 cycles of that. And that was then followed by weekly Taxol, which is another chemotherapeutic agent, for 12 weeks. So it was a long course that she went through, but she had an excellent response to treatment. So clinically, I would say by about halfway through treatment, I could no longer feel the tumor. And remember, initially, the whole lower pole of the right breast was a hard rock. And halfway through this, I could really not feel anything. The breast then had a normal appearance at that time. Halfway through treatment, or about 2 months into her treatment, we got this ultrasound, which did show decrease in the size of the tumor. Now remember, you have to take that with a little bit of a grain of salt because the ultrasound initially was not representative of the entire tumor size, but it did help us follow the treatment response. So this was excellent. So she had an excellent clinical response to treatment. After much discussion, this patient opted for bilateral mastectomies. We also, even though clinically she was node negative, which means there were no abnormal nodes appreciated on physical exam and there were no abnormal nodes seen on imaging, you still are obligated in this situation to perform a sentinel node biopsy, which the sentinel node, remember, is the first draining node of that area of the breast. And it's really important to make sure there's no disease in the lymph nodes on a microscopic level. She also, because of her age, she opted for no reconstruction. So we went to surgery. She did well. The final pathology showed that there were 2 sentinel nodes removed at the time of surgery, both of which were negative for metastatic tumor. There also was some additional axillary lymph node tissue that I removed, and that actually had 5 lymph nodes in that specimen, and all of those lymph nodes were also negative for metastatic disease, which is excellent. The right mastectomy specimen showed that there actually were 2 tumors in the breast. The main tumor, which had initially been biopsied and which was the hormone receptor negative tumor, is this listed down here, this tumor number 2. And you can see for that tumor, she had a complete pathologic response and there was no evidence of residual viable primary neoplasm, and that is excellent. So she had a complete response for the hormone receptor negative tumor. The tumor bed measured 15 by 9 millimeters, but again, there was no malignancy seen. Interestingly, though, she had a second tumor, this one that was listed as tumor number 1. That was an incidentally identified tumor, not related to her initial hormone receptor negative tumor. This tumor actually had different prognostics than that first main one. This was a grade 1 tumor, and it only measured 5 millimeters, and it ended up being a hormone receptor positive tumor, which was completely different than the hormone receptor negative tumor that she presented with initially. And sometimes we do see this. You can see 2 different tumor types within the same breast. That's not unheard of. Now, that tumor had no chemotherapy-related effects seen, and what that means is that it didn't respond to the chemotherapy. That also is common for a low-grade hormone receptor positive tumor. Those generally don't respond well to chemotherapy, and you have to remember that the tumor that was driving all treatment decisions and that will also drive her outcome is this hormone receptor negative tumor. So the most important thing is that that hormone receptor negative tumor had a complete response. That being said, though, the staging does have to include that second 5 millimeter tumor. So let's look at this. So staging after treatment. So it has a designation of a Y because that signifies that she had some sort of neoadjuvant treatment. M means that there are multiple foci of disease. And then the P means that this is the pathologic staging, which means the staging after surgery or on the surgical specimen. So when you put it all together, it's a YMP T1A, and remember, this is based on the size of the largest residual focus of disease, which was 5 millimeters, right? It's not based on the size of the tumor bed. So like if you go back here, this 15 by 9 millimeters, that is not what you use to do the T staging. You use the size of the largest residual viable tumor, which is here, 5 millimeters, okay? And so that's how you get the YMP, T1A, N0, M0. That's the staging after all her treatment was completed.
Hello, thank you, Dr. Garreau. I'm Peggy Adamo from the NCI SEER program, and we'll be going over the 2 breast cases, the abstracting and coding for each of the breast cases. First of all, I'd like to thank my two colleagues, Lois Dickey and Jennifer Rule, who were very helpful and guiding me and answering my questions as I was preparing this presentation. For each case, we'll go over the following topics. We'll go over the primary site. We'll talk about the solid tumor rules as far as determining the number of primaries and the histology rule. We'll cover the grade fields. We'll talk about extent of disease, summary stage, and all of the SSDIs. And jumping right in, breast case number 1. This was a right breast primary. For primary site, we assigned code C509. Our case information tells us that there were 2 tumors. One was in the upper inner quadrant, and the other one was described as being in the lower inner quadrant or lower breast. In the solid tumor rules, you have table 1, the very last row, and the note, bullet 1, says for breast NOS, which is C509, you use that code for non-contiguous multiple tumors in different quadrants or subsites of the same breast. And that's what we have here. We have 2 tumors, one in the upper inner quadrant and one in the lower breast or lower inner quadrant. So 2 separate subsites of the breast. We determined the number of primaries for this case, and we determined that it was a single primary using rule M13. M13 says to abstract a single primary when synchronous or separate non-contiguous tumors are on the same row in Table 3 in the equivalent terms and definitions. And the same row means that the tumors are the same histology, which would be the same 4-digit ICD-10 code. And both of our tumors in this case were invasive ductal carcinoma, so they're exactly the same. That fits M13 and gives us a single primary. For the histology, we assigned 8500/3 using rule H12. That's invasive ductal carcinoma. On page 32 in the solid tumor rules, it says code the histology diagnosed prior to neoadjuvant treatment. Prior to neoadjuvant treatment, for this case, we had a single tumor, invasive only, and a single histology. So pretty straightforward. It was invasive ductal, and that's an 8500/3. Looking at the grade fields, grade clinical, we assigned a 3. This case describes a core needle biopsy of the right breast lesion as invasive ductal carcinoma grade 3. We can assume in this case that grade 3 refers to the preferred grading system for breast, and G3 equals a code 3 for grade clinical. Grade path, we had chemotherapy. This case received chemotherapy before the definitive surgery. So it did not meet the criteria for grade pathological, and in that case you assign a 9 to grade pathological because neoadjuvant therapy was given, which means that it did fit the criteria for grade post-therapy, and we assigned a 1 there. The mastectomy said that there were 2 tumors, and for tumor 1 was described as invasive ductal carcinoma grade 1, and that's a code 1 in grade post-therapy. The EOD fields, we assigned code 100 for EOD primary tumor. Code 100 means any size tumor confined to the breast tissue and fat, including the nipple and or areola, localized NOS. And that's definitely what we have for this case. None of the tumor extended to any nearby structures or extended beyond the breast. EOD nodes, we assigned 000. This patient did have neoadjuvant therapy, and the general rule for cases with neoadjuvant therapy say that the highest category is to be assigned. If clinical is higher, you assign that. If pathologic is higher, you assign that. But if the 2 are the same, the clinical takes priority. There's a note in the EOD manual, note 4, and there's a clarification coming for 2021, and it's for cases with neoadjuvant therapy. It says, if the clinical and pathological information are the same, code the extension based on the clinical information. The 2 are equal in this case. They're both negative. So the clinical code of 000 takes priority. You may be wondering why you wouldn't code 070 for the pathologically negative, and that's because when the case has had neoadjuvant therapy, the clinical information takes priority over the pathologic when the two are the same. So again, 000 is the preferred answer for EOD nodes. EOD METs, it was pretty clear there were no distant METs, so we assigned 00 there. Summary stage, this case was localized. We assigned a code 1 for summary stage, localized, confined to the breast. By the way, there is a revised EOD manual available for cases diagnosed in 2021 and later. In that manual for breast, there are some clarifications regarding EOD nodes. The clarifications pertain to the use of clinical versus pathological codes for breast nodes. Be sure to check the change log that's posted with the manual and see what's new. Let's look at the SSDIs, starting with the ER or estrogen receptor data items. For ER summary, we assigned a 0. The information in the medical records said that the ER was negative at 0.1%. Code 0 is what reflects that information the best. Percent positive, we assigned 000, ER negative, or stated as less than 1%. And we had both documented in the medical record. It was stated as negative, and the percent was 0.1%. The ALRED score, we assigned X9 for unknown. You might be tempted to assign a 1 there. With ER less than 1%, you could have put the proportion score as a 1. However, there's no intensity score specified. You could have guessed that it's a 0, and then you would have an ALRED score of 1 because it's the sum of the proportion score and the intensity score. But we felt that since the intensity score was not stated, that the unknown code would be preferred in this situation. So we assigned X9. I want to point out this reference that's in the SSDI manual on page 174. This table shows you how the proportion scores are assigned for the ALRED score and the intensity score. This applies to both estrogen receptor and progesterone receptor. So make a note of this reference to help you with the ALRED score in the future. Moving on to the progesterone receptor data items, we assigned a 0 for progesterone receptor summary. The medical record stated that PR was negative at 0%, so that's a code 0. PR percent positive, we assigned 000. It was stated to be negative, and that is a code 000. For the ALRED score, we went ahead and assigned 00 to this one because we know that the PR was negative and 0%. ALRED score measures positivity, so if there are no positive cells, then the ALRED score is 00. So you might have been tempted to put an unknown there, as I was, but I was told, and it was explained to me that since we know everything's negative, there's no positive cells at all, 0%, we can go ahead and put the ALRED score as 00. Moving on to the HER2 SSDIs. For the overall summary, we assigned a 0. HER2 was stated as equivocal at 2+. Code 0 for the summary includes HER2 negative and equivocal, so that's a code 0. For HER2 summary, we assigned a code 2. Code 2 means equivocal, and as we just talked about, it was stated as equivocal in the medical record. For the HER2-ish summary, we assigned a 7. 7 means the test was ordered, but the results are not in the chart. In the medical record, there was a statement saying FISH pending, so that pertains to the ISH study. That's where the 7 comes from. The test was ordered, but the results are not in the chart. Then for each of the ISH data items, the DP ratio, the DP copy number, and the ISH SP copy number, all of those are coded as XX.7. which means the test was ordered, but the results are not in the chart. And that's, again, based on the statement in the case information that says fish is pending. It was ordered, but we don't have the results. In the SSDI manual on page 186, it says that the simplest test used is the IHC, the immunohistochemistry. And if the IHC test is borderline or indeterminate, an ISH test in situ hybridization may be performed. And that's what we're seeing in this case. They did the IHC test and it was equivocal. So it looks like they ordered the fish and we just did not have the results available to us. And looking ahead to 2021, for NCI SEER, NPCR, and COC, the IHC summary data item, the ISH summary item, and the ISH DP ratio, DP copy number, and SP copy number data items will no longer be required. So for 2021 cases, you don't have to abstract those data items anymore. If you are in a COC region, an NPCR region, or a SEER region. However, if you're in Canada, you still must collect the IHC summary and the ISH summary, but you don't have to collect anymore the DP ratio, DP copy number, and SP copy number. So no matter where you work, starting in 2021, you will have fewer SSDIs to abstract for breast, and that should be good news. Moving on to the next set of SSDIs, looking at Ki67. Ki67 is a marker of cell proliferation. A high value indicates that a tumor is proliferating more rapidly. In our case information, we had a statement that said the proliferation rate was high at 91%. For the Ki67 data item, that translates to a code of 91.0. That's for 91% proliferation rate. The Oncotype DX score, the DX recurrent score for invasive cases, is coded as XX9, which means it's not documented in the medical record. We did not have that information, so it's XX9. Same thing for Oncotype DX risk level for the invasive cases, also a 9. We did not have that information. For the next two data items, they pertain to DCIS, ductal carcinoma in situ. So the first one is XX6, which means not applicable, invasive case. Because our case was invasive, it was not a DCIS case. And the second one is coded as 6, which is also not applicable, invasive case. So those two become not applicable, the other two are unknown. Next, let's look at the final three SSDIs. Multi-gene signature method is coded a 9. We didn't have that information. It's not documented in the medical record. Multi-gene signature result is also unknown. That's a code X9, not documented in the medical record. And response to neoadjuvant therapy is a 9, not documented in the medical record. For this SSDI, a managing physician statement regarding the response to neoadjuvant therapy is required. Our information in the case study is from the pathology report, and there's no follow-up from the managing physician. So you have to code that a 9. You need all of the clinician to gather all of the information to assign this code. The pathology report alone is not sufficient. And there is a note 1 in the SSDI manual for this data item that says, clinician statement of response to neoadjuvant therapy or treatment effect must be used to code this data item. So that means that in this situation, the pathologist does not qualify as the clinician because they're only reporting what's on the pathology report. And the code in response to neoadjuvant therapy must be based on the pathology report plus clinical findings after neoadjuvant therapy. There's another note that says, note 2, review the medical record for a specific statement by a clinician about the response to neoadjuvant therapy. Response is based on pathology report, imaging, and clinical findings. And that's because a pathology report could show a complete response. However, a PET scan could show metastases. So you need a clinician statement that pulls all of that information together. pathologist statement is not sufficient on its own. So we coded a 9 for that. And that completes our review of the coding for breast case number 1. I believe we will have time for questions. Back at your desk when you're working on cases, if you have questions about primary site, solid tumor rules, extent of disease, or summary stage, please submit those to Ask a SEER registrar. If you have questions about the SSDIs or grade, please submit those to the Cancer Forum. Thank you.
All right, well, let's move on to our second case then. So case number 2 is patient CT. This is a 37-year-old female who developed the sudden onset of redness and swelling of the left breast. She also generally was not feeling well. She had malaise, fatigue, fevers, and because of all of this, she presented to urgent care. In urgent care, they diagnosed her with a left breast cellulitis because that's what it looked like. I mean, her whole breast was red, she had fevers, and she was given a prescription for antibiotics. Unfortunately, despite the antibiotic prescription, she continued to have fevers and worsening redness of this left breast. So as a result, she then presented to the emergency room the next day. In the emergency room, she was noted to have fevers up to 38.5 degrees Celsius. She had an elevated white blood cell count at 21,000, which is very high. So then she was admitted to the hospital for IV antibiotics. She did get better with the IV antibiotics, and she was discharged 2 days later and then sent to the breast center for imaging to evaluate for an abscess. At that time, there was no concern for a cancer because all of her symptoms and presenting physical exams seemed most consistent with an abscess. So she went and got an ultrasound of the left breast, and it did not show an abscess, but it did see at least 2 masses in the left breast that were concerning for malignancy. So at that point, the treatment recommendation shifted and more imaging was recommended, and that's what I'm going to show you. So to start off, she also had a diagnostic mammogram, which remember that means you're looking at a specific area of concern. Now, I'm not sure if you can appreciate it on these images, but she had a large span of what's called malignant appearing calcifications. And the calcifications are these little white dots, if you will, kind of looks like grain of sand. Not all calcifications are concerning, but when they're really small or microcalcifications and they have different shapes, which is called pleomorphic calcifications, those are concerning for a malignancy. And her span of calcifications was 11 by 10 centimeters in this view, and it was essentially the same. It was almost 12 by 9 centimeters in this view, and that's a very large span of malignant appearing calcifications. Now on this one view here, you can see the radiologist left me another love note, which I really appreciate. And they're pointing to this irregular mass here, which looks like an irregular lymph node possibly, but it also looks like maybe it's a little bit inflamed. So they're pointing that out to me too, that looks concerning for possible involvement with cancer as well. So she then went on to get an ultrasound, and the ultrasound showed at least 4 different masses that looked concerning. This is one of them, and let me get my little pointer here. So you can see here that it's, again, this irregular hypoechoic solid mass. Those are all terms that mean it's concerning for a cancer. And on this measurement, it was about 3.7 centimeters by about 1.8. This is the same mass, but just seen in a different view. And in this view, it measures about 1.5 centimeters. I also put up these pictures, which are looking at 2 additional masses in different areas of the breast. You can see this one is in the left breast at 12 o'clock, 11 centimeters from the nipple, and this one is at 7 centimeters from the nipple. And these are just the pictures that I brought up here. Again, the radiologist saw at least 4 different areas that looked concerning. This is the ultrasound of her axilla or the armpit, and these are incredibly abnormal looking lymph nodes. You can see they're really large. In fact, this one almost is as large as the largest mass that we saw in the breast on ultrasound. So it's large. And then these other ones here, they're more rounded, which that's actually a bad feature for a lymph node, and that suggests involvement with cancer. You can see that it's black. That also is concerning. This means that this lymph node is completely replaced with tumor, and it looks very concerning. So based on all of that, she had an ultrasound-guided core needle biopsy of the largest left breast mass, as well as the most suspicious-looking left axillary lymph node. And what these pictures show, this little white thing in here, that's the tissue marker, or the clip that we place at the time of the biopsy. That way, when you go to surgery, I can make sure I remove the area that was previously biopsied. But that's the clip in the lymph node. And you can see the clip here in the breast mass that was biopsied. And again, that just allows me to go back and make sure I've removed the proper area. So her biopsy results showed that that left breast mass was an invasive ductal adenocarcinoma. It was classified as a grade 2 to 3. When it gives a grade range like that, I always use the highest grade in terms of the staging. This was technically hormone receptor positive, with the estrogen receptor expression being 3.5% and the progesterone receptor expression being 1%. But that expression rate is so low that we essentially treat this as a hormone receptor negative breast cancer, because that's what it's behaving like. This cancer was HER2 positive, 3+ on the initial H&E staining, and that just means this cancer is overexpressing that particular protein. The proliferative rate was again quite high at 49%, not as high as our last patient, but still pretty high. Now, interestingly, even though I showed you that those lymph nodes looked very abnormal and concerning for cancer on the ultrasound, the biopsy actually just showed fragments of a lymph node with focal necrosis. The pathologist then did something called cytokeratin stains, and that's a special stain we use to determine if the cancer cell, or if there are cancer cells there. And it did show rare scattered cytokeratin positive cells, but the pathologist that felt that because they were located outside of the tissue, that they were not sure if they were cancer, and they thought maybe they were contaminants. I can tell you though, just based on that imaging alone, that those lymph nodes are definitely malignant. So anyways, the pathologist said, well, you'll need to correlate this with the final surgical results. But again, just based on that imaging, I would consider those involved with cancer. So I then met the patient. And on exam, it was very obvious that there was something wrong with the left breast. The left breast was much larger as compared to the right. It was swollen. It was red, particularly on this upper area. The nipple looked concerning for involvement with something called Paget's disease. Paget's disease is essentially just breast cancer in the nipple tissue, and that is commonly associated with an underlying malignancy. So sometimes you see that. The nipple, though, was completely effaced and scabbed over. I mean, it didn't even look like a normal nipple. She also had that palpable mass at 12 o'clock. That was the mass that was biopsied. And on my exam, that felt to be about 3 centimeters, but the entire breast looked abnormal. And on exam in the axilla, she had what I felt to be firm, matted lymph nodes, and that just means that it feels like they're all kind of mushed together, if you will. And it's just like a hard packet of lymph nodes in the armpit area, and that's very concerning. She also had some erythema around one of the enlarged lymph nodes, which looked concerning for a possible infection, which I'll get to in a second. The patient said it was new since the biopsy, but I suspect that was what caused her to have fevers and the elevated white count. The redness, that's what I was referring to. So then she had a breast MRI, and unfortunately this doesn't completely do justice to what we saw, because I only was able to put a few slices up. This one here shows the largest mass, and again, the colors, that's, remember, like I said from the last case, those are the kinetic views. That's the uptake of dye that we see. And these, again, are concerning features for cancer, so you can see it's quite large. Down here, this thing here, that's the lymph node. That's that largest lymph node that was biopsied, and you can see it's enlarged. It also has worrisome kinetic features, which again suggests that this is involved with cancer. This is just a different view of a different area. This is another mass, and you can also see the blue up there in the nipple. That also suggests that there's involvement of the nipple, which, remember, on physical exam we could see that also. Now, just so you know, the report by the radiologist said that there were over 20 distinct lesions in the left breast, kind of scattered throughout. And so I'm only showing you a couple of them. This one, this main one, there's kind of another little one here, but over 20 different discrete nodules. So her entire breast was just riddled with cancer. So let's talk about her staging. So her clinical staging, which is based on my physical exam and the imaging that we have, was a T4D N2M0. And remember, T4D is a specific designation for inflammatory breast cancer, which I'm going to talk about a little bit more in a second. The N2 designation is because she had those matted lymph nodes. Matted lymph nodes on physical exam gets the N2 designation. And then clinically, there was nothing to suggest she had metastatic disease, so she was given an M0 staging. So the anatomic staging, which again, remember, that means the size of the tumor, the status of the lymph nodes, and the presence or absence of metastatic disease, her anatomic stage was a 3B. The prognostic stage, which also includes the hormone receptor status, the HER2 status, and the grade, also was a 3B. In this situation, it didn't change. They actually were the same. So I wanted to talk a little bit more about the staging for inflammatory breast cancer. One thing that's really important is it's very important to distinguish an inflammatory breast cancer from a locally advanced breast cancer. Sometimes they can look the same, but clinically they're not the same and they're treated differently. So specific to an inflammatory breast cancer, this generally is rapid onset of erythema, like redness, swelling. You can get something called peau d'orange, which is like dimpling of the skin on the breast, and that's due to infiltration of the tumor in the lymphatic tracts. So, and you can have an underlying palpable mass like our patient. And one of the key things is the duration of history is no more than 6 months. If they've had these symptoms longer than 6 months, that just means it's a cancer that's been kind of growing and doing its thing. That would be a locally advanced breast cancer. But when the symptoms come on really suddenly in less than a 6-month time period, that is how you diagnose an inflammatory breast cancer. And also, an inflammatory breast cancer is a clinical diagnosis. That means if you think it looks like it on physical exam and it looks like it based on history, then it's an inflammatory breast cancer. Now, you may also have read that sometimes we do what's called a punch biopsy of the skin. And what that is you're looking to see if there's cancer cells in the dermal lymphatics. While that's helpful information, that is not necessarily diagnostic for an inflammatory breast cancer, and you do not absolutely need to have a punch biopsy of the skin to diagnose an inflammatory breast cancer. And then obviously you need to have pathologic confirmation that there is a cancer associated with this. So that's all I have to say about that. Okay, so we also did a staging workup because patients that present with an inflammatory breast cancer oftentimes will also present with metastatic disease. And so these are some pictures of the bone scan. And again, you can see here the radiologist has an arrow pointing to this little tiny black spot, which it's really hard to see. That actually is a feature that's concerning for a metastatic lesion in her left ninth rib. Now you might ask yourself, how is this any different from all of this other stuff? I gotta be honest with you, I just trust my radiology friends. They tell me that it's concerning. They have a bunch of different pictures that I don't have. The other thing is they compare it to the CT scan, and you can look on the CT scan and see if the lesion on the bone view looks concerning for a metastatic lesion. And so when they put all that together, that's how the radiologist can figure out whether or not these little spots that they're seeing here are concerning for metastatic disease. But this was concerning for metastatic disease. That was the only focus of disease she was noted to have on her staging workup. Her CT scan was negative. So this again changes her staging though, right? So I didn't have that information when I first met her. So based on this now, so she's still a T4D, because remember that's the designation for an inflammatory breast cancer. She's still N2 because remember that indicates that the lymph nodes are matted or fixed to one another. But now she's an M1 because the bone scan was suggestive of metastatic disease to that left ninth rib lesion. And so now, unfortunately, she's no longer a stage 3B. She's now a stage 4. The good news, though, is it was a single site of metastatic disease. And when it's in the skeletal system, like the bones, those women still actually tend to have good outcomes, much better than if they have visceral metastases, which means it metastasizes to like the lung, the liver, or something like that. So anyways, based on, again, her presentation, pretty aggressive cancer, she also was recommended to have neoadjuvant chemotherapy. She had almost the same course as our last patient. Remember, she had that dose-dense AC followed by the weekly Taxol. The difference in this patient is, remember, she's HER2 positive, and we actually have a lot of drugs that target cancer cells that overexpress that HER2 gene. And that's why in the past, HER2 positive breast cancers used to be considered more aggressive, but now because we have all this targeted therapy, a lot of these women actually have pretty good outcomes. And so the two targeted therapies we have for HER2 overexpressing breast cancers are Herceptin and Perjeta. And those are given in addition to the standard chemotherapy regimen, and those are continued for a full 12 months. But because those two drugs are targeted, these women tend to not have side effects from it, like their hair grows back, they get their energy back, stuff like that. So that's the only difference with this patient, is she had those two HER2 targeted therapies added. Now, she also had an excellent clinical and radiographic response. I also would say about halfway through her treatment, her breast looked completely normal, which, remember, on initial presentation, it was swollen, it was enlarged, the nipple just looked like a scab, completely normal about halfway through treatment. couldn't feel that mass anymore that I could feel in the upper part of the breast. The lymph nodes I could still feel, but they were much smaller as compared to what she initially presented with. And then ultrasound follow-up of this showed decrease in all the masses that had been noted previously. So she also went on to have bilateral mastectomies. The only difference in this patient is because, remember I said she presented with those matted lymph nodes? Because I knew she had multiple lymph nodes involved and she presented with an inflammatory breast cancer, she was not a candidate for that sentinel node biopsy procedure. So she actually had to have a full axillary lymph node dissection. That means taking all the lymph nodes out in that armpit region. Now she also had something called LYMPHA at the same time. That stands for lymphatic microsurgical preventive healing approach. It's just a fancy way of saying they reattach the lymphatic tracts to try to lower the incidence of lymphedema, which is that swelling of the arm. And that is seen more commonly after you've had a full lymph node dissection. So that's the only extra thing that was added on her. And then she had an excellent response to treatment. So her final pathology after surgery showed that all the lymph nodes were negative. Oh, I just realized that there's a typo. Oh, no, that is correct. 0 of the lymph nodes were positive, meaning they were all negative. There were 10 removed at the time of surgery. One of them had something called fibrosis or scarring. And what that means is it previously had cancer in it, but the chemotherapy killed it all. So you just see scarring afterwards. So all the nodes were negative after her treatment. And then she had a tiny residual 2 millimeter tumor. That's all that was left. So she almost had a complete response, but there was just that little bit of 2 millimeter tumor. Now you'll notice her tumor bed is 2 centimeters by 18 millimeters. But remember, when you stage them, it's based on the largest focus of residual viable tumor, not the tumor bed. So, and that's just what I was emphasizing here. And so let's talk about her staging. So she again has that Y designation, which means neoadjuvant treatment. The P again means pathologic. So this is the final staging based on the pathology from surgery. She gets a T1A designation because the largest residual viable tumor only measured 2 millimeters. Remember that T1A is any size less than 5 millimeters. She's now an N0 because all those lymph nodes were cleared of the cancer that they had before. And then now here's the interesting thing, the M stage doesn't change. So she was M1 initially on clinical staging, and so she still is an M1 regardless of the response to treatment. Again, she's YPT1A N0, but the M still stays M1. So after she was done with all her surgery, she went on to get adjuvant radiation to the chest wall and the lymph node regions. And then she also got radiation to that single focus of metastatic disease in that left ninth rib. And she did great with all of that. She, at one point, those Herceptin or those HER2-based therapies, she was switched to something else called TDM1 because even though she had an almost complete response, it wasn't quite a complete response. And there's data showing that if you don't have a complete response, you need to get switched to this other medication, that TDM1. Unfortunately, though, she wasn't able to tolerate that because of other side effects, so she went back to the Herceptin and Perjeta. And then on repeat imaging of that bone lesion, they can no longer see it, which is awesome. But remember, because she was M1 initially, she still is staged as an M1. But now she's doing great. She's 16 months out from her last treatment, and there's no evidence of disease. So there's actually a good chance that she's going to have a really good outcome. And that's all I have to say. So thank you again for the opportunity to present these cases. This is my dog Gino, who's 18 years old, and I don't know if you can appreciate it, but he only has 3 legs, so he's a little miracle too. So again, thank you so much for the opportunity to be here. Thank you.
Thank you, Dr. Garreau. This is Peggy Adamo again from the NCI-SEER program, and we will go over the abstracting and coding for breast case number 2. This case was quite complex, and it was difficult to fit into our rules, but we'll go over that as we move along. For primary site, we assigned C508, and that is overlapping lesion of breast. The involvement in this breast, the left breast, was described as being at 12 o'clock, being between 9 o'clock and 3 o'clock, and all of it. Upper breast was also stated. All of that translates to a code of C508 for overlapping lesion of the breast. Determining the number of primaries, we determined that this is a single primary. The best choice in this case is M8, and that's for the Paget and invasive ductal. We'll capture the inflammatory carcinoma in the staging. Again, this was a complex case, and it was challenging to use the rules for this case. For histology, again, complex case, doesn't fit nicely into our rules. The medical record said clinically the left nipple was very concerning for involvement of Paget's disease. And then after the neoadjuvant therapy, the mastectomy diagnosis showed Paget's disease of the nipple. We coded 8541/3 using H19 for Paget and infiltrating duct. In the breast rules, the coding histology section, 3A and 3B cover the ambiguous terminology for coding histology, and that refers back to that clinical diagnosis of Paget's, which says concerning for. But that information in the histology rules does not fit this case very well. It doesn't really cover what we're looking at. And Paget's disease is rarely, if ever, treated with neoadjuvant therapy. Surgery, post-op, XRT, and chemotherapy are the standard. Since in this case, the neoadjuvant treatment was given for the underlying ductal and not the Paget, we can use that post-treatment diagnosis of Paget to code the mixed histology. And you're going to say to me, well, where is that in the rules? It's not there. The rules were written to cover 90% or more of our cases. If we wrote rules that covered every case, they would be enormously long. We cover the majority by far. If you run across a case like this where the rules are just not working for you, that's when you consult with Ask Us Your Registrar. And that's why we're there, to help with things like this. And there shouldn't be very many of them. There are some, and this happens to be one of them. Let's look at the grade fields. Grade clinical, we assigned a 3. Our case information told us that the grade was 2 to 3, a range of 2 to 3. There is a cancer form question on this that says when you have a range, you take the higher number. So the higher number in this case would be a 3. The range of 2 to 3, we coded clinical grade as 3. The ultrasound-guided breast biopsy of the largest mass, the final pathology showed that the left breast mass at 12 o'clock was an invasive ductal carcinoma grade 2 to 3. So that's where that came from. Grade path doesn't apply to this case. There was neoadjuvant therapy, so it did not meet the criteria for pathological grade, and that in that case we assign a 9. Grade post-therapy, it did meet the criteria for grade post-therapy. There were bilateral mastectomies after the chemotherapy, and we had a diagnosis of residual invasive ductal carcinoma grade 3. So we assigned a 3 for grade post-therapy. Looking at the EOD and summary stage data items, for EOD primary tumor, we assigned 600. This means diagnosis of inflammatory carcinoma, and this is how we pick up the inflammatory carcinoma information. We're picking it up here in the staging fields. The physician clinically staged the patient as a T4D, and that correlates to code 600 for EOD primary tumor. EOD nodes, we assigned 350 for clinical assessment only of fixed or matted axillary lymph nodes. In the case information, we have a statement that says, she has a firm, palpable lymph node in the left axilla. I actually felt that this was felt to be matted lymph nodes. So that's where the matted lymph nodes comes from, and the code of 350. For EOD METs, we assigned a 70. 70 means bone other than adjacent rib. We had a solitary osteoblastic MET in the left 9th rib. And you may notice that the physician assigned an M1, and code 70 for the rib fits with the physician's assignment of M1. For summary stage, we assigned a 7, which is distant, and that's also based on the METs in the rib, and it also correlates with the physician's assignment of M1. This is a discontiguous lesion, so that's how we get to the 7 and the 70. The SSDIs are mostly unknown for this case, but we'll go through them. For the ER summary, percent positive, and all-red score, those are all codes for unknown. We didn't have any information in this case about estrogen receptor. The same goes for progesterone receptor. We had no information, so we assigned all these codes for unknown, 9, XX9, and X9. HER2 summary, HER2 data items, same thing. We didn't have any information on HER2, so all the codes are for the unknown values. The Ki67 and the Oncotype invasive data items are unknown. The Oncotype recurrence score for DCIS and the Oncotype diagnosis risk level for DCIS are not applicable because this is an invasive case. The multi-gene signature method, the result, and the response to neoadjuvant therapy are also unknown. We'll talk a little bit about response to neoadjuvant therapy. We coded it as a 9, not documented in the medical record. And again, you may recall that I talked about this on the previous case. For this SSDI, you need a managing physician statement of the response to chemotherapy. And for this case, it seemed all we had was from the pathology report. So that does not qualify, and we have to code that as a 9. And that concludes our review of the data items for breast case number 2. We should have time for questions. Again, back at your desk, if you have questions about primary site, solid tumor rules, extent of disease, or summary stage, please submit those to Ask a SEER registrar. If you have questions about the SSDIs or grade, please submit those to the Cancer Forum. Thank you very much.
Hello and good afternoon. Welcome, everyone. So my name is Vanetta Williams, and I will be your moderator for the Q&A case studies this afternoon. We have our presenters for the breast cancer case studies. And so first we have Dr. Jennifer Garreau, and then we also have Peggy Adamo. So Dr. Garreau and Peggy, thank you very much for being here. We appreciate you and just setting aside time to be here live with us. So we greatly appreciate it. And so we'll go ahead and get started with answering questions live. And so Dr. Garreau, you can go ahead and get started.
Okay, thank you everybody for being present and for the excellent questions, which by the way, I'm not a tech person and I don't understand how this works. So as the questions were coming in, I've been madly typing the answers and then they were like, no, you could have just done that now. And I was like, oh, okay. So anyways, so I'm gonna go back to all the things I answered and see if I'll read the question and then I'll answer it as best as I can. So this is gonna be very out of order. So I'm just, oh, can you guys hear me?
Yeah.
Okay. This is going to be really out of order because I'm kind of just going from the top of what I'm seeing on my screen. So there were a lot of questions regarding the second case, the 37-year-old that had the lesion that was suggestive of a metastatic lesion. So the issue is when we were first working her up, that lesion definitely looked very suspicious. In fact, it was pretty definitive for a metastatic lesion. The issue though is, it's always a little bit hard to objectively call it metastatic, particularly when you're dealing with a 37-year-old. There's the whole emotional component that the doctors have. Like, I didn't want to call it metastatic because you just don't want it to be. But objectively, you guys are correct. You can't make diagnoses based on suggestions. So we had a lot of debate, the medical oncologist and I and the radiologist, and ultimately we decided that yes, that was definitely a metastatic lesion. And so that's why we called her M1 disease. But thank you for bringing that up. And you're right, you're not supposed to stage based on ambiguous terminology. Let's see what else. I want to make sure I get through all of these. A bunch of you asked me about using the SN as a suffix. And I have to confess, I never do that. I don't know why. Since you pointed it out, you are absolutely correct that technically, since it was a sentinel node, you do have to use the SN suffix. I don't know. I always just use N, but you guys are correct, and I'll start changing it because that is the proper way to stage it, is with the SN suffix if you've done a sentinel node. So thank you for pointing that out. And then someone had a question about the post-staging after treatment for the 37-year-old with the inflammatory breast cancer. So I mentioned in the slides that the YP was only for the T and the N. That is absolutely correct. You do not restage the M. That part is decided at the initial workup, and you're either M0 or M1. So I apologize if that was confusing, but the point I was trying to make is the YP part is actually only for the tumor in the node. The M part stays the same. It's whatever you were staged initially. And then some people had a couple questions about the inflammatory breast cancer. You know, that also sometimes is confusing. But in short, it's a clinical diagnosis. So if it looks concerning for inflammatory breast cancer and the onset is within less than 6 month time period, then you classify it as an inflammatory breast cancer. People had some questions about locally advanced, and that generally is because it's some sort of like neglected tumor that for whatever reason people didn't seek treatment. But inflammatory breast cancer is onset of symptoms within less than 6 months. Okay, and then and then someone mentioned something about how we shouldn't use anatomic staging. You know, ever since the new AJCC guidelines, we now use prognostic staging. That is correct, but I still include that information. And as you guys know, you all collect it for that way we can compare it to the prior staging. And also some parts of the world, actually, they don't have that molecular technology. But yeah, so anatomic staging, I just list that to include the tumor and the nodal status, but that is correct. We, as you guys know, all use prognostic staging. And then someone asked something about the actual stage versus the physician stage. And I'm not sure what the difference for that is. I compile all the information I get. It is confusing, I absolutely agree. But I put everything together, all the different imaging modalities and the physical exam. And what I do is based on all of that information, I use the largest extent of disease for the T stage classification. So for example, if in our first case, the MRI showed the largest extent of disease, right? Because the ultrasound didn't reflect the actual size. And also the physical exam correlated with the MRI. So I use that for the clinical staging. For the T part. So that is confusing, but I'm not sure what they mean by actual stage versus physician stage. I just go based on the objective data that I'm given, and I make the best assessment based on that. So it's confusing, but I generally use the largest extent of disease, whatever imaging modality that is. Sorry, I'm going through all the questions you guys sent. Oh, sorry. I'm trying to, so on the first one, there were questions also because there was that second focus of disease found on the final pathology. So that what second focus of disease was a second primary, and that had completely different prognostics. That one was estrogen receptor positive and progesterone receptor positive. The primary triple negative tumor, that one had a complete response. And so one of the questions was about how to code that. And I don't know how to answer that because I'm not sure how you guys code it. We staged each of those separately. I don't know if that makes sense. Like the triple negative was one tumor, and then the 5 millimeter ER-PR positive tumor was another one. So they got staged differently. So I'm assuming you would code it differently, but I'm not sure. And then that first case, it was HER2 negative. I apologize if that didn't come across on the slides, but it was reported the FISH was negative for amplification. So we definitely had objective evidence to suggest that that was definitely a triple negative.
And Dr. Garreau, at this time, can we hand it over to Peggy to answer some
definitely. I'm sorry, I've been trying to hog it. Thank you so much for everything, and thank you for keeping track of me.
Hi. There was a question about which data items are going away in 2021. that we don't have to code anymore, and I'll just repeat what they are. HER2 IHC summary, HER2 ISH summary. Those are going away in the US. I believe Canada will still require them. And then everybody will be losing or not coding in 2021 HER2-ish DP ratio, HER2-ish DP copy number, and HER2-ish SP copy number. So I think that's probably some good news. And some of these questions are really in depth, and I'm going to have to take some time and consult with my colleagues to get answers to you. So I'll do that in the time after the presentation's over and tomorrow, and as long as I can, as long as it takes to get you some answers. I thought there was one more that I could answer quickly. A lot of people had a question about, where was it? Why weren't the lymph nodes, the EOD lymph nodes coded 070? Well, that's actually what I put down on the case when I first worked it, and Jennifer Rule corrected me and told me that since there was neoadjuvant therapy, you prefer the clinical information over the pathologic information. So 070 is a code for pathologic status. The 000 is the code for the clinical status, and that's preferred in that situation. So I got it wrong too, but I learned what to do now. Let's see, what else can I answer for you? People were asking about where that's documented and if you can use that rule now. Yeah, you can use it now. It's a clarification. You'll find the documentation in the 2021 EOD manual. I believe there's a number 4 under lymph nodes. Look there. If you have questions, shoot us a question in Ask Us Your Registrar, and we'll get that information out to you, which will be much more clear than me trying to take it off the top of my head here. Let's see. Somebody asked about EOD in general. If they're not in a SEER area, do they need to do EOD? And the answer is probably no. If you're in a SEER area, you will have to code EOD. You already know that. If you're not in a SEER area, then you probably don't have to code EOD. So one less thing for you to do. I think there was some information shared in Dr. Garreau's presentation that I didn't have access to when I did the cases. So one of the things I'm going to do is go back and watch her presentation and get the updated information. So I apologize for that. There might be a little disconnect between what was provided in the case summary and what I used to code the cases and do my presentation versus what Dr. Garreau just shared with you now. So we'll get that synced up. There were a bunch of questions about the response to neoadjuvant therapy. Is that the right name for this data item? Hang on a second. Yeah, response to neoadjuvant therapy. And that was another one that Jennifer Rule and I talked about a lot. She tells me that to code that data item, you must have a managing physician's input, their summary, their statement. And that has to be based on clinical information, pathologic information, and imaging. So one of those 3 things is not enough. There was a question, well, what if they said what if the managing physician said that pathologically they showed a response? Well, that's only one of the 3 pieces, the pathologic piece. And my understanding is that you need the summary from the managing physician that ties all of the pieces together, the clinical, the imaging, and the path to code that data item. So that's my understanding, response to neoadjuvant therapy. I'll pause there and see if Dr. Garreau has any more to share with us.
I'm sorry if I didn't give you all the information.
Oh, it's okay. I mean,
sorry.
We'll work it out. We'll get it worked out.
Okay, sorry.
Are there any other questions you would like to answer live, Dr. Garreau?
I feel like I got most of them. That one everyone kept asking on the first case. Yes, it was a typo. I'm so sorry. It was not supposed to be pathologic stage. It was prognostic. And I don't know. I didn't write it down properly. So a ton of people asked about that. So you guys are absolutely correct. It was supposed to be with the first case, it was the prognostic stage, not the pathologic stage.
Okay. Okay, so if that'll be it. So what we can do now is that if both of you can kindly provide us with some final thoughts, as well as if any of the conference attendees have additional questions, what's the best way to contact you? And Dr. Garreau, we'll start with you.
Okay, sorry. I would say just send me an email. Now, Robin knows sometimes I'm not great about email. I will eventually get back to you, but you guys can email me, and my email is J as in Jennifer, and then Garreau, Garreau at LHS.org. I'd be happy to answer your questions. Just apologies up front. It might take a little bit, but I will get back to you.
Thank
I
you.
may be the first person to take you up on that. So
Okay,
stand
yeah,
by.
especially because I didn't give you enough information apparently.
Oh no,
I'm
we'll
so
get it straightened
sorry.
out. Somebody did ask where questions get sent, for me to restate that. So ask us your registrar, send us your primary site, solid tumor rules, EOD, and summary stage questions. Questions about the SSDIs and grade go to Cancer Forum. So that should cover it for these pieces of information. You can always email me, but ask us your registrar and Cancer Forum are the places for the technical questions. And I will get back to the questions on this and fill them in as best I can with help.
Okay, awesome. We thank you very, very much for your time and for being here. Great presentation. Thank you for being here live. And so for all of the conference attendees, the presenters have provided some feedback to you in the Q&A section. And if you go back, they will be posted. If they have not been posted yet, they will be posted very soon. And this will also apply to all of the previous presentations from yesterday as well. So we thank you for attending and see you in the next case study. Thank you.
Thank you.
Thank you.